Hello everyone. Today we'll be giving an overview of common infections and immunization in pediatrics. So these are the various diseases we'll be talking about. So these are the various viral illnesses and bacterial illnesses we'll be talking about. Firstly, regarding measles. Measles is a highly contagious disease spread by airborne, and it is caused by measles virus, family paramyxovirus. And what we need to remember is outbreaks are seen where communities are with low immunization rates. So immunization is paramount in avoiding outbreaks, and patients are generally contagious about 5 days before to 4 days after appearance of pathognomic rash. Clinical features are the child will have a prodrome of fever, cough, coryza, conjunctivitis, and there is a pathognomic morbilliform rash which appears in a cephalopodal way and also fades in the same order. And there are something known as Koplik spots, which are gray white spots on the buccal mucosa, and skin may be squamate as well. Next, complications of measles. So measles can lead to otitis media, pneumonia, croup, subacute sclerosing panencephalitis. SPE is a fatal complication of measles. It is progressive degenerative encephalitis, which is characterized by intellectual deterioration and seizures. It is almost 100% fatal, and it is diagnosed with the help of raised antibody titers in the serum or CSF. It is also a clinical diagnosis when verified with serology. Treatment of measles is generally supportive, and vitamin A supplementation is also shown to decrease mortality, especially in malnourished patients. Coming to rubella, it is caused by rubella virus, and it is also transmitted via droplets or direct contact. And individuals are contagious from few days before to 7 days after the onset of rash. And clinical manifestations, most of the infections are asymptomatic infections. And rubella infection can produce mild erythematous maculopapular rash along with fever and lymphadenopathy. When rubella is contacted during the antenatal period by mothers, it can lead to teratogenic association, can lead to congenital rubella syndrome, classic triad being cataract, deafness, and cardiac abnormalities in the baby. Diagnosis is mostly clinical as well as IgM serology, and treatment is supportive in case of rubella as well. Next, roseola infantum. The causative is a human herpes virus 6 and 7, and the primary infection peaks between 6 and 24 months of age. The transmission is likely to occur from contact with respiratory secretions from asymptomatic adults who are caregivers, and once the individual has been infected, the virus persists in latent form throughout the life. This is a picture of an infant affected with roseola infantum. And clinical manifestations typically presents with 3 to 5 days of fever. So the rash comes after the onset of fever is what we need to remember. And it appears on the trunk and spreads to the extremities, neck and face as the fever resolves. Complication is encephalitis and encephalopathy. Diagnosis is clinical as well as PCR is available and treatment being supported. So this slide shows us various diseases which we talked about. So rubella is ordinary measles, rubella, as well as roseola infantum. So like we told, based on this, we can differentiate. You can see in the first picture, the child is shown to be having Koplik spots, which is pathognomic. So So this is how you can differentiate between all these three diseases. Next, coming to chickenpox. It is caused by varicella zoster virus and it is transmitted by direct contact as well as air droplets. And symptomatology, there will be symptoms of fever, malaise, anorexia, which may precede the rash by a day. And initially there are small red papules that rapidly progress to non-umbilicated and oval teardrop vesicles on the erythematous base. And every 3 to 4 days, you'll be having new crops of these rash. And humans are the only natural hosts, and pruritus is universal. And severity of rash varies as to systemic signs and fever, which generally abate after 3 to 4 days. Laboratory testing and confirmation is usually unnecessary. And whenever you see a child with, so this is an image of child with chickenpox. You can see that various stages of lesions are there on the child. So once the scaling starts, it means that the child is no more infected. And treatment is symptomatic, complications being secondary infections with streptococcus or staphylococcus, which are most common. And neurological complications also are seen, such as post-infectious encephalitis, ataxia, as well as nystagmus and tremors. Next, coming to mumps. Mumps is caused by mumps virus, and clinical manifestations are fever, headache, malaise, as well as myalgias are seen with swelling of salivary glands. You can see in this child, there is swelling of parotid as well as submandibular salivary gland. So it depends. Mostly it is bilateral, but in some children, unilateral mumps is also seen. Complications being meningoencephalitis, orchitis in pubescent males, myocarditis, as well as pancreatitis. Diagnosis is clinical, which is supported with serology, and treatment is supportive. Next, coming to pertussis. It is caused by Bordetella pertussis. It is a respiratory infection caused by a gram-negative aerobic coccobacilli. Clinical manifestations being there are 3 stages in clinical manifestation. You have a catarrhal stage, paroxysmal stage, where there is this paroxysms of continuous cough, and then there is a convalescent stage when the symptoms resolve. The paroxysmal stage can last for 1 to 3 months, and it is associated with the classical inspiratory food. Diagnosis is with the help of clinical history as well as peripheral blood leukocytosis with lymphocytosis, PCR or culture. Treatment being erythromycin for 14 days or azithromycin for 5 days, and infants younger than 6 months might require hospitalization as well. Coming to viral hepatitis. So viral hepatitis, mostly it is asymptomatic or mild. And it is caused by 5 primary hepatotropic viruses, which differ in their characteristics. What we need to remember is hepatitis A and E are transmitted via fecal-oral route, and hepatitis B, C, and D are transmitted via IV drug use, sexual or perinatal modes. Manifestations. So you have 2 phases. There's a pre-icteric phase and an icteric phase. Pre-icteric phase lasts for 1 week, characterized by headache and anorexia, malaise, abdominal discomfort, nausea, and vomiting. And icteric phase consists of jaundice and tender hepatomegaly. So this is the most common physical finding, having tender hepatomegaly. So this diagram shows an overview of all the various viruses. What you can see is each and every virus has its own incubation period. Like we told, fecal-oral route is seen in hepatitis A and E, and One more thing you need to remember is chronic infection is seen in case of hepatitis B, C, and D. And, specific prophylaxis is only available for A and B. As well as hepatitis B vaccine can be used in case of viral hepatitis B. So like we told earlier, one of the main physical signs are of tender hepatomegaly, which is also reflected by hepatic enzymes, which increase by 15 to 20 fold. Here, alanine aminotransferase, aspartate aminotransferase, and are elevated. And whenever there is parenchymal inflammation, and ALP as well as 5-nucleotidase are increased, which shows that there is a degree of cholestasis. So based on the investigations, you can know which part of the liver is affected. And what they also say is asymptomatic or mild non-specific illness without icterus is more common in case of hepatitis A, B, and C. And it's especially seen in young children. And prothrombin time is a good predictor of severe hepatocellular injury and progression to fulminant hepatic failure. So these are things you need to keep in mind. Coming to the next disease is hand-foot-mouth disease. This is something which is very commonly seen. It is caused by Coxsackie virus. It occurs with a direct contact with nose and throat secretions of infected person with incubation period of 3 to 5 days. Symptoms being sudden onset of fever, sore throat. Then there is small grayish blisters in the mouth that last for 4 to 6 days. And blisters may appear on palms, fingers, soles for 1 to 2 weeks. The mode of spread is coughing and sneezing. So how do you control? So you avoid close contact with children who have hand-foot-mouth disease. You have to have a careful disposal of their soiled articles, and isolation of the child with fever and pending diagnosis is to be done. Treatment-wise, majorly it is symptomatic treatment with acetaminophen for fever, and prevention is with the help of good hand washing and hygiene measures at home, particularly in daycare centers. Next, coming to dengue fever. So I'm not going into detail of the disease. I'll only talk about clinical manifestations of various dengue illnesses. Coming to dengue fever, which is transmitted by mosquitoes, Aedes aegypti, cause being arbovirus. And Aedes aegypti can cause yellow fever, dengue fever, chikungunya. And what we need to remember is the dengue serotype. There is a short-term cross immunity. So a person who's affected with one particular serotype, it's not like it doesn't provide complete immunity. The person can get infected with the other serotype as well. So these are the clinical features of dengue fever. So patient may suffer with fever, headache, muscle and arthralgias, myalgias and arthralgias, nausea and vomiting, rash and hemorrhagic manifestations. Clinical manifestations, when we talk about in dengue, there is a spectrum of disease. It can present as an undifferentiated fever, it can present as a classical dengue fever, or it can present with severe forms such as dengue hemorrhagic fever as well as dengue shock syndrome. So dengue hemorrhagic fever, there will be hemorrhagic manifestations such as skin hemorrhages, gingival bleeding, nasal bleeding, gastrointestinal bleeding, hematuria, as well as increased menstrual flow. We have to keep in mind about these signs and symptoms, which are signs of encephalitis or encephalopathy, such as decreased level of consciousness, seizures, nuchal rigidity, or paresis. And coming to the unusual presentation of severe dengue, we can find children having features of encephalopathy, hepatic damage, cardiomyopathy, and severe gastrointestinal hemorrhage. So these are the various features which a patient with dengue fever can present to you. I haven't gone into details of the treatment part. So once dengue is diagnosed with the help of clinical manifestations as well as supportive serology such as NS1, IgM, and IgG. So IgG gives us information regarding previous infections. So NS1 and IgM is important. So once you are diagnosed it, then you need to institute management based on the clinical presentation. Next, coming to impetigo. So this is one of the common bacterial infection you see. It is caused by staphylococcal or streptococcal. In this picture, you can see the child is having a yellow crusted sores surrounded by redness. Whenever there is contact with new area, it can lead to formation of new sores. And mode of spread is through direct contact and can spread from person to person via hands. And here you need to see the incubation period for staphylococcal is 4 to 10 days and streptococcal is 1 to 3 days. And majorly the treatment is by help of antibiotics. So you have to start antibiotic therapy as soon as possible and avoid any close contact with infants and debilitating people because it can lead to debilitating disease, widespread disease. And you have to keep the affected areas clean and covered. Keep the nails short and clean. There is pruritus, so you can give an antihistaminic as well. And wash hands frequently and avoid sharing toilet articles. So this is regarding impetigo. Coming to scabies. Scabies, you can see in this image. It is caused because of sarcoptes scabi. It is an infestation where there is intense itching, especially in the nights. There is a pimple-like rash that may be present. There can be a pustule at the end of the burrow. The pathognomic lesion is a burrow with a pustule, and itching and rash may be present all over the body. One thing we need to remember is it can also be present in areas where there is, mostly we tell there is lesions near the webs of fingers and toes, but it can occur in other parts as well, such as all the flexures, elbows, armpits, groin area, waist, buttocks as well. And like I told, there are tiny burrows that look like gray white lines. So you need to be vigilant if such a child is there in your wards. You have to institute treatment as soon as possible with permethrin. And mode of transmission is direct and indirect, with incubation period being 2 to 6 weeks in people who have not had scabies before. And contamination period until mites and eggs are destroyed by treatment. So you have to see that all the mites and eggs are destroyed. You also tell them to remove all their used clothes and wash them separately so as to kill all the eggs and mites. Coming to the next illness is malaria. It is caused by Plasmodium and it is spread by female Anopheles mosquito. We have 5 species of Plasmodium again. You have Plasmodium falciparum, Plasmodium vivax, Plasmodium ovale, malaria, and Knowlesi. Knowlesi is rare, but we need to remember about falciparum, which can cause severe malaria, and Falciparum vivax as well. Sorry, Plasmodium vivax as well. Coming to mode of transmission, it is either with vector transmission, direct transmission, as well as congenital infections are seen. Vector is by bite of female Anopheles mosquito, and direct transmission is by injection of infectious blood or plasma. Symptomatology, you have 3 stages: cold stage, hot stage, and sweating stage. Cold stage is associated with the onset of fever with chills and sensation of extreme cold. In hot stage, the temperature may rise up to 106 Fahrenheit. There is intense headache. And in sweating stage, which follows hot stage, is fever decreases with sweating. So these are the 3 stages you can see. And diagnosis is typically by microscopic examination of blood film. So you have a thin film and thick film. Thick film is helpful to know the viral load as well as the species as well. And with antigen-based rapid diagnostic testing also you can diagnose the malaria. And one more thing is the method that use the polymerase chain reaction to detect parasite DNA have been developed, and they are a bit costly, but it helps in rapid diagnosis. Coming to tuberculosis, it is caused by Mycobacterium tuberculosis. And the mode of transmission being droplet infection because of produced by sputum of positive patient as well as coughing. It is not spread by fomites as such. And signs and symptoms. The patient may present with tiredness, malaise, loss of appetite, loss of weight, anemia, evening rise of temperature, sweating, especially during sleep, cough, as well as hemoptysis in case of advanced stage. We can diagnose tuberculosis with the help of sputum for AFP. We can take gastric lavage and bronchoalveolar lavage in small children, as well as culture is helpful in diagnosis of tuberculosis. And you can get a chest X-ray done to see if there are any signs of tuberculosis, if there is any miliary tuberculosis, or if there is any increased hilar lymphadenopathy. And one more investigation that is used now for the diagnosis is CBNAT, which is scattering-based nucleic acid amplification test. So these are the various diseases I wanted to talk about in this topic. Next, we'll be covering regarding immunization in children. So immunization schedule is given by, this is the IAP immunization schedule which I have projected. So what we need to remember is vaccines are of 2 types. There is a live vaccine and killed vaccines. Live vaccine, they mimic natural infection, but they do not cause disease except in immunocompromised hosts. So most of the time we deal with children who are immunocompromised. So we need to keep in mind of all the live vaccines that can lead to disease in case of immunocompromised children. So by live vaccine, what I mean is MMR, which is measles, rubella, and mumps. Then there is hepatitis A vaccine, that is also a live attenuated vaccine. BCG, oral typhoid, oral polio, rotavirus, as well as yellow fever. So all these come under live attenuated vaccines. We need to be mindful when we are thinking of giving these vaccines in children. And next, you have killed or inactivated vaccines. These vaccines can be given to all the children. So this includes whole cell pertussis, inactivated polio virus, which is nothing but injectable polio, IPV, rabies, and hepatitis A. Few forms of killed vaccines are available in hepatitis A, as well as influenza. And diphtheria comes under toxoids. So diphtheria, toxoid, and tetanus toxoids. So these can come under toxoids. So these can also be given in immunocompromised children. So here you can see that there are various colors here. So the recommended age of these vaccines are given in yellow. You can follow them up. Suppose if a child is not available, you can get them vaccinated during the catch-up range accordingly. So each vaccine, whenever given, mostly there is a gap of 4 weeks to 2 months. So it depends on the kind of vaccine you're giving. Rotavirus, you don't give if you're not giving by 14 weeks time. If you haven't given even a single dose before 14 or 15 weeks, you don't give rotavirus furthermore, because it is to be completed before 14 weeks. And you can see in blue, there are vaccines which are to be given in special situations, such as meningococcal, Japanese encephalitis, cholera. Then you have pneumococcal vaccine and rabies as well as yellow fever. So these are the vaccines that are to be given in case of special situations such as cochlear implantation, children with chronic liver, renal diseases. So all this in special situations, you would give these vaccines. Lastly, this is again immunization schedule from a normal hospital. So this is how you can give the vaccines starting from birth till 10 to 12 years. With this, I finish my presentation. Thank you.